And Matteo, can you let me share my screen, please?
Oh, sure, yeah. Now you should be able to.
Perfect. Okay, great. Okay. Okay, can you see it properly now?
Yes, we do, yeah.
Okay, great. So I think my objective today have two for one. I think I've been asked to talk about the SURTAVI 5-year data briefly. That was presented at TCT. I think the manuscript is still being prepared. And then to talk more about, how do we decide TAVI or TAVR versus SAVR in younger patients? Because that's really what we are discussing now at all our heart team meetings. So let me this is my disclosures. So these are presented by Nicholas von Meegem last year at TCT. So just very quickly go over the data. I'm sure you already looked at it, but in essence, to summarize, the SURTAVI trial is on patients with so-called intermediate surgical risk. And this is a global trial involving both European and US sites. And you can see the STS score were as follows. And based on the heart kidney evaluation, they were randomized to TAVI or versus surgery. And also they have patients with a concomitant coronary disease that were either randomized to TAVR plus PCI and surgery plus CABG. I presented that last year in London Valve in a virtual format, but they were a pretty small group of patients. And so now remember this trial, they were still using the first generation core valve in almost all the cases, only about 16% were repositionable and recapturable, and most of them were transfemoral, but there were a few alternative access. So you can see that there are about almost 1,800 patients who got randomized, pretty equal in both groups. And you can see that at 5 years, these are the patients who were alive to the end. So pretty good follow-up, well over 90%. So what are they looking for? All-cause mortality or disabling stroke. They also look at some hemodynamic numbers that you see here, any kind of aortic valve reintervention, rehospitalization, and of course, the quality of life now, just like in all the different trials. So you can see that the baseline characteristics very similar in age. Females, STS score, in terms of comorbidities, really no differences. And that's the essence, of course, of a randomized trial that includes also the frailty score of the 5-meter walk speed. So in terms of mortality of disabling stroke, you can see that in surgery is 30% at 5 years. This is a composite endpoint, and with TAVR is exactly overlapping, really absolutely no difference between the two. And if you look at the landmark analysis, there were no really early dropout in the surgical arm or the TAVR arm, so they were exactly parallel pretty much even at the first 30 days. So when you do a landmark analysis, really there's no difference at all afterwards. All-cause mortality, very similar to, in terms of comparing the composite endpoint. That's because that the very stroke rate is quite low. And you can see that here, disabling stroke. There was a little bit earlier signal with surgery here. You can see the early divergence in hospital, but they were pretty much parallel afterwards. Now, here's some of the other outcomes. So we talked about mortality and stroke already. Reintervention was very low. You can see that here there was a statistically higher number. You can see that here 3.5 versus 1.9%. But afterwards, from the second year onward, is pretty similar. So most of the reintervention were early. And endocarditis, very similar, no difference. Thrombosis, no difference. Heart failure hospitalization or aortic valve hospitalization was similar as well. And of course, no surprise, the pacemaker rate was significantly higher with the TAVR side. But interestingly, even surgical arm, the pacemaker was still almost 10% and 15% at 5 years. So, I mean, these patients are, almost 80 years old, so they have some underlying conduction system disorder. Again, if you look at reintervention, at 5 years, we're not just talking about mortality and stroke, but how many patients come back needing the valve redone. And you can see that here, initially there were higher rate, and there's early separation between the first and in the first year, I would say, and then afterwards it was parallel. And if you look at rehospitalization, it's pretty much the same thing. The surgery actually did better than TAVR, and then afterwards it's the same. Hemodynamics, you can see that here pretty much consistent with all the other self-expanding supraannular valves. The EOA typically were larger than surgical valves, and the gradients were lower than the surgical valves. So pretty consistent, pretty stable gradient in both surgical and transcatheter valves. So that's important to note as well. So in terms of AR and PVL, again, this is, remember, first generation core valve used most of the time, no external wrap. So you can see that at least about 30% of patients had mild PVL, even at 5 years. And you can see that's total AI, and then 27% at 5 years. And there are some moderate as well. KCCQ score, again, this is very much consistent with all the other trials. What you see is that TAVR definitely have an early recovery because it's not open surgery. But you can see once you made it out to first year, if you survive, you do well with no major complications, both therapy are essentially equivalent. So after the first year, yes, surgery, you will have an upfront hit, even with minimally invasive surgery, you still need to be on the heart-lung machine and with cross clamp and as an incision. So you still have a bit of the quality of life recovery to make up to, but once at 1 year, it's very much the same with TAVR and surgery. And MIJ class is also the same, no difference between the two groups. So the summary of the trial, essentially, as I mentioned before, no difference in composite primary endpoint. More intervention with TAVR typically earlier, but after 2 years, the same. The rest of the key endpoints were similar, except obviously paravalvular leak had more with TAVR and also pacemaker as well, but there are low rates of reintervention. So my take on this is that essentially in carefully select the patient, after all, this is a randomized trial, their anatomy was evaluated, and there's really no difference between the two with the core valve versus surgery. Interestingly, there was really no impact on PVL or pacemaker mortality, because otherwise you would have seen that early on in the 1 year, 2 year outcomes, but they seem to be pretty much similar in the both arms. So it'll be interesting to do a deeper dive on that. You can see that the hemodynamics is superior with the self-expanding supraannular valve versus SAVR. There was a higher intervention, and I would say probably likely because, remember, this is mostly first generation valves. So they probably likely need to be re-intervened because either deep implant, as we all recall the early core valve days with paravalvular leak, maybe pop out. So they might need to be dealt with, but now it's extremely rare because now the devices are so much more advanced. And no surprise again with quality of life is similar once they're 1 year with no difference between the two groups. So I want to switch gear a little bit on TAVR in younger patients. I want to show you this US data. Of course, you guys have the Gary registry as well, but this is pretty interesting. This I just got from Michael Mack, actually on the latest data up to 2020, because it's always 1 year beforehand. And a few important observations in the United States, in 2015, TAVR is already bigger, exceeded isolated AVR at that time, and that was before low risk approval. This was after intermediate risk approval. Now, fast forward, you can see that now 2018 onward, TAVR has now overseeded all AVR, meaning including root replacement, AVR cabbage. You can see that all here. And what's remarkable is that at the end of 2020 now, this is COVID. Remember, COVID started that year despite COVID. And I think that's something to do with that. The surgical volume had just completely plummeted. Look at the decline. You would have a difference of 30,000 cases between TAVR and surgery. And you can see that, dropping almost 20% drop between pre-COVID versus during the COVID year. So this is something that'll be very interesting to watch in 2021 and 2022. And I'm sure probably similar observation in Germany and Europe as well. So I break it down when we talk to the heart team with the patient about, in a young patient, young meaning that I know, European guidelines, now 75 or greater, but in US it's 65 or greater being recommended for TAVR over surgery, or at least equal. You can see that, first of all, is transfemoral approach feasible, and can we achieve a surgical-like result? Those two are very important points to make, because if you're young, you don't want to have to come back sooner for valve intervention or treating a PVL. And alternative access have not shown to be superior to surgery. So transfemoral is really the default approach, and of course now is well over 95% of transfemoral. And then the next question you ask is mild PVL okay? So far, we have not seen any signals of leading to mortality. But remember, this is not going to happen probably at least 5 to 10 years. It's too early right now, even the low-risk trial with 2-year follow-up to demonstrate any of that. Again, left bundle branch block and pacemaker have been shown to affect outcomes, particularly in mortality as well in high-risk patients. So we have to see, you certainly don't want to have that as a young, low-risk patients. And then we'll focus more on the coronary access, which your group has done a lot of seminal work in, and of course, lifetime management as well. When the transcatheter valve fails, what are the options to fix it? So in the interest of time, I'm going to skip the middle two items because that is pretty much well known, but other items I think are important. So we all do a CT analysis on these patients, whether they're for surgery or TAVR. You do it just so that you have the anatomy in front of you to be able to have an informed discussion with the heart team, because there might be hostile anatomy, like for example, in this case, with annular alveolar calcium, that surgery might be preferred, particularly in very young patients, 65 to even 70 years old, because we want a lifetime management option for these patients. And typically, if you do SAVR, you'll likely be able to do a TAVR afterwards. So we're not worried about having to do re-op SAVR anymore in most of these patients, because they typically have reasonable and generous anatomy. And of course, you look at the sinus tubular junction, the sinus valve salver, but more importantly, what you're looking for is, are there any risks of left main obstruction? And I would say that in a younger patient, left main stenting is not something that we would like to recommend in that age group, just to protect the left main from a TAVR procedure. And also, we look at this anatomy now also for considering redo TAVR. So some patients ask now, well, if the first valve failed, can I get a second valve without surgery? And the answer comes to the CT scan, because now we know some root anatomy are more favorable for redo TAVR. And if not, they might have to do TAVR explant. And of course, femoral approach has to be favorable as well. So let's fast forward to CAD. Why is CAD important? Well, you can see that all the trials, 40 to 75% of patients have concomitant CAD. They may not require intervention, but they will eventually may do that. And even the low-risk trials, you can see that there were about 30% of patients with concomitant CAD that need to be managed and observed. And of course, you now know that there are randomized controlled trials to actually randomize patients to TAVR and PCI or versus medical therapy. And of course, the success rate of post-TAVR angiography of PCI vary among patients from patients, and the valve choice being choose. So I think one of the concerns is that there are a lot of interventional cardiologists there who don't do TAVR, who don't know much about the technology, and they don't know how to reaccess the coronaries. And that every aortic root anatomy is different. There's the aortic valve leaflet that's in the way. There's the transcatheter valve stand frame in the way. And of course, the commissure alignment issue as well. So there are a lot of barriers in play for coronary access after TAVR versus surgery. So here are two examples of why coronary access may be difficult. The left side, you can see bulky leaflet facing the left main. You might not be able to selectively engage the guide directly to the left main, particularly in a low anatomy situation. And then the right side, you see with a valve-in-valve situation, you have a very small STJ, low left main. It's going to be very difficult to cannulate the left main directly because of the distance and the angulation. And this is a paper we published in JACC a few years ago now, looking at some anatomical and procedural and device features on coronary access. And we actually have an app and a website that my interventional partners put together with and I, so that we can teach people how to do this. So now, then the topic commissure alignment came up because in surgery, we've done that routinely. We align the commissure. We'll never put a commissure post in front of left main because you cannot come off bypass. But here, the situation is that the more important thing is that taller stand frame valve that can create a physical barrier. And also with TAVing SAV, you may reduce the risk of coronary obstruction. And also with the redo TAVR now having been discussed, if you have commissural alignment, you may be able to reduce sinus sequestration and coronary obstruction. There's some early data that it might affect halt and gradients and durability. And if you have a commissural post in front of a coronary, you can't really do any leaflet management strategy to reduce that risk. You can't do basilica to splice a commissural post. So first, what we do is look at the aortic root anatomy on CT and look at which valve you have. And the shorter valves, like the balloon expandable, mechanically expandable, are more important for reduced TAVR, while the taller stent frame valves, like the evolute, acroneo, or portico, may be important more for coronary access and reduced TAVR, even though it's intraannular position. This is an editorial I wrote recently, looking at some of the factors involved in both, and you can see commissural alignment, in my opinion, are important in both. And what is commissural alignment? For the cardiologists who may not be familiar with this, what that means is that your alignment with the native commissure. So you can see here, this is a free finus for SAVR, and with the transcatheter valve with the spokes representing commissural post, the green means that you have a large open space to reaccess the coronary because you have just stent frame in the way. Versus the right side, you have seen the commissural post is already occupying a portion of the space. And remember, the TAVR commissural posts are like triangular in shape. They're not very taper and thin. So you have some space that occupies there with a fabric that will prevent you from accessing the coronary just by the means of a physical barrier. So this is exactly what I meant. So you can see here when you have misalignment, this is a TAV in SAF example, but you can see the blue shaded area is a barrier to coronary access. And if you have that facing the coronary, like on the right, bottom right figure, you're gonna have a more difficulty accessing. That's just a mechanical calculation. That's not nothing that would be different. And you can see that here. So if you have coronary arteries, like the red circles, with commissural misalignment, you now have to go from the cells on either side represented by the red axis, versus on the right side, if you have optimal alignment, you have much more open cells available to you to engage the coronary, even at if it's a low coronary. So you can see that here, we do see that on post-CT. So this is a study that looked at coronary access, and about 20% of the time of the self-expanding valve, and about 11% of the time the commissural post faces one of the coronary, which may reaccess more difficult. Now, if TAV in SAP, people ask, well, why does commissural alignment matter? Here's the two examples. If you have very tight quarters and you have risk of coronary obstruction, even with basilica, right? So these two mitral flow valves have leaflet split already. But if you have a commissural post facing that split portion, all your hard work went to waste, because now the commissural post is going to obstruct the coronary, not the valve itself. So that's why it is important, I think, even with TAV in SAF, to have commissural alignment in these situations. So we work with a couple other, several other centers in this paper that we published a couple of years ago on, can we actually do something to improve alignment? So with the SAPIEN 3 valve, we have not been able to do that consistently. We try to crimp the valve in different orientations, and you can see that here, there's pretty much some equal distribution. Now with the evolute, you can improve the alignment, and we've shown that as well. You can see that with the flush port 3 o'clock, when you insert in the femoral artery, you do the cusp overlap view like is shown here, and you can see that the C paddle would be facing on the right side of the screen when you deploy the valve and the cusp overlap view, and that shows you with good alignment. And we now have done over 500 cases with this technique. We actually looked at a more recent experience with over 350 cases compared to our early experience. You can see that 97% of the time, we can actually achieve the head marker in the favorable position in the outer curve or center front at the time of deployment. Now, it's not a perfect technique. It's not meant to achieve commissural alignment in this with this device, unlike the Yana valve, for example. So we only achieve commissural alignment around 80% of the time, okay? But that's better than before, which is only around 60% of the time. So you can see, particularly with this particular valve, the coronary overlap with the commissural post really decreases significantly. And I think that's going to be important for coronary access with the evolute platform. And this paper by Tarantini's group showed that if you have commissural alignment with both evolute and the acroneo valve, your ability to re-engage the coronary selectively went from 46% to 71%. So basically went from 89% overall selective and non-selective to 97%. So that's, I think, an important improvement given what we have right now with technology. So folks, the balloon expandable valve is pretty much certain that you can get selective engagement. So now with the Lars Søndergaard's group have now published this paper showing that it's not just the evolute valve, you can do it with accurate neo, you can do it portico as well, to try to improve commercial alignment in a more consistent manner using the cusp overlap view. And now actually there's some more advances of study. This group looking at what if the coronaries are not 120 degrees apart, which actually quite often to be the case. So can you find a way to compromise the rotation of the valve to such that you're not going to have an overlap with the right coronary, because that's the more variable situation. So what they call is the coronary overlap. So meaning that your C-arm will rotate it to overlap the coronary artery. So you split the difference such that one of the commissural posts will be symmetrically split between the two coronaries. And in fact, what you do is you have to go a little bit more areocaudal, which can be challenging in some patients, but that's how you do it. And this paper on the same issue of from Spain, looking first, you would go a little more areocaudal. You actually can mark the coronaries on CT and maybe even on fusion technology. And then now you go more areocaudal to overlap the coronary to try to split the difference between the two. Again, it's a technique that we modify to help with the coronary alignment when your coronaries are not 120 or 130 degrees apart, especially in the bicuspid case. So I think in summary, the current devices are not designed to achieve commercial alignment. I think the data now shows that can make coronary access easier and maybe even redo TAVR. In terms of technical modification now, we typically do the evolute at 3 o'clock and the accurate neo2 at 6 o'clock. So finally, lifetime management. These patients are not likely going to outlive their valve. What kind of reintervention may be possible? So this JACC imaging paper published a number. You can look at some of the anatomy involved. So I bucket into 3 different categories. So first, you look at the STJ dimensions. Second, you look at the THV leaflet height, or we call now the neo-skirt height, because that leaf is going to pin up against the frame. And then finally, the implant depth of your first valve. And you can see that here, if you have a narrow STJ, a high, tall leaflet valve, or you implant the valve high, you're going to likely seal off the STJ and cause coronary obstruction if you do TAVR and TAVR. And this is the example here, looking at this paper from looking at CT data. If you look at the Evolute Pro platform, if you do an Evolute or SAPIEN 3 Evolute, if you seal off the STJ, you're going to cause sinus sequestration. And this can also happen with SAPIEN 3 and SAPIEN 3 or Evolute SAPIEN 3. So you really have to look at the anatomy of the native aortic root relative to the valve to determine what the risk is. This letter we published in JACC Intervention a couple of years ago showed that there are really, in my mind, 3 different root anatomies look at TAV and TAV feasibility. So the first anatomy is type 1, wide open, big sinuses, the valve is well within, no problem. The second type is that basically the STJ is close to the sinuses, and you can see you need to measure this distance here for clearance, especially with the, if your first valve is the balloon expandable one. And if this distance is very small and narrow, you're not going to be able to do it because you're going to cause sinus sequestration. The type 3 is really the valve now extends all the way above the STJ. So you really need to look at this distance here. And if that distance is too small, like you see here, you're not going to be able to do a TAVR and TAVR. And so we actually had a provocative paper just that came out in CCI showing that in borderline sizing, rather than implanting a larger valve and oversizing right to the annulus, maybe we can actually undersize with ultra and actually have no difference in PVL or stroke on any other endpoints. But now you have a better clearance in terms of the STJ and the root to be able to enable you to redo TAVR. So this example here on CT with a modeling here with 26 Ultra versus the 29 S3, same patient. If you do 80-20 on the 26 Ultra, you expand a little bit more, maybe add a couple cc, you're going to be able to redo TAVR, no problem. Even if you implant the valve at 90-10, no problem. But if you use the 29 S3, it's now bigger and taller. If you implant 80-20, you know, that's going to be a little bit borderline now. And if you implant even higher, you really now exclude yourself the possibility of redo TAVR. So in our center, we now routinely in borderline cases or heavily calcified cases, we would prefer to undersize and overexpand rather than the other way around. And also, it reduces any kind of risk of annular rupture. So now, why is commissural alignment matter in redo TAVR as well? Look at this example here. So remember, the leaflet height is going to be determined by your leaflet, where it is. So you can see that in the SAPIEN 3 is all the way at the top of the frame. Same for Lotus. In Evolut, it's all the way up to 26 millimeter. In Accurate, depends on the valve, it's all the way up to 31, and Port goes around 26 to 29. Now, if you have commissural alignment, you drop that neo skirt down to really just the ceiling skirt, because now you can potentially have leaflet management strategy like basilica or other means to remove that leaflet or split that leaflet to reduce that ceiling skirt height. And we demonstrated this with a tutorial from a paper, look at coronary access. You have 2 transcatheter valves in place. So what we looked at is that if your first valve on the top part, type 1 anatomy, is below the coronary, really the first valve, the commissural alignment does not matter. But the second one does, because then you would make it more difficult to reaccess the coronary if your second one is misaligned. Now, if you look at the other one, if you look at the type 2 anatomy where you have the first valve taller than the coronary or position taller with the neo skirt taller, the first valve commissural orientation is going to matter because you're going to have to probably split that leaflet first to make some room, because otherwise you really jail yourself from after the second valve goes in to be able to even remotely access the coronary. Now, it's not just basilica now. There have been some technique modified basilica, such as balloon assisted, to really open up that first valve leaflet to make more room, because when you put a second valve in, this can be reduced because it pinned the leaflet in an unpredictable manner. So that's another option as well. So finally, if you cannot do redo TAVR, you're gonna have to explant the valve and do surgery on this patient. And I can tell you that most cardiologists think, well, it's the same as first-time SAVR. It's not. It is really not. And your center has a lot of experience with this, and you can speak from your center's experience. You can see that with surgery, you take out the native valve, you debulk any calcium, there's nothing left, and you have clean tissue plane, and you implant a surgical valve. But if you, and that's why redo SAVR, it's really still straightforward, because there's a plane that you can clear between the surgical and the annulus. There's no frame or native valve in the way, and we don't typically injure the LVOT or the mitral valve or the ascending aorta. Now, if you have TAVR explant, there are 3 factors that determine how difficult it's going to be. First, you have the native leaflet stuck to the valve, and it can be harder to remove the whole thing. Second, the device is stuck to the annulus and the LVOT or the aorta. So now you have endothelialization. It's a little harder to define a tissue plane. So if you injure the aorta, you're going to have a risk of dissection. You will repair it. If you injure the annulus, you might have to patch it. And also, in the self-expanding valve, you can go all the way to the ascending aorta. So what that means, you have to open the aorta higher to be able to get to the valve. You might have to, cannulate the aorta more distally. It certainly may increase the complexity of the surgery itself. And finally, depending on how deep the TAVR valve is implanted the first time, so it can impinge the membrane septum anteriorly for the mitral valve. So now you have a VSD situation to repair. You might have, actually, we've seen several cases that impinge on the mitral valve leaflet. So now you have MR. So you cannot repair the mitral valve. You have to replace it because the anterior leaflet is fibrosed and it's stiffened because of the impingement of the anterior mitral leaflet through the aortomitral current. So it's not just isolated AVR in these patients. And you can see from the data out there that a lot of them had concomitant surgeries. And you can see here, these are intraoperative pictures from this paper showing that you can injure the aortic root, injure the membrane septum, injure the mitral leaflet, or even injure the aorta. So it's not just a straightforward redo AVR. And this paper we published last year with collaborating with your group as well, looking at the TAVR explant. You can see that here, the mortality in hospital and stroke rate is pretty substantial. Now, granted, these patients are typically complex, a lot of comorbidities, but about 20%, 25% of patients in our series actually were deemed by the heart to be low surgical risk. not intermediate or even high risk. So, this is the composite mortality. We're looking at kind of the stratification right now, looking at low risk versus intermediate high risk. And I don't think we actually saw a difference in terms of mortality or stroke. So even low risk patients can be pretty complex. Now, of course, this is still early in our experience. Now I think people are learning how to do this better, and I think the outcomes will be better. Now, let's say you feel that it's too risky to take the whole valve out because the patient, you really want to shorten the clamp time, do a straight simple case. Well, this case report from this center near us basically take the leaflet out because that's the issue in hand in terms of coronary obstruction, and directly implant a sapien 3 valve inside the frame of the evolute or core valve. And sure, because there's no issue of coronary obstruction, it went very, very well. You can see that here they even get a left atrial appendage clip in there to prevent stroke, and you can actually do also mitral repair if you need to. So you can see that that's very feasible. Now, this final slide shows what are the sequencing. What valve should the first patient use? Now, remember, a lot of these patients, their life expectancy is not going to be 20 years. Okay, a patient who's 80 years old, the life expectancy is typically 5 years at most in the general population, 5 to 10 years. Once you go to 70-year-old, maybe 10 to 12 years, and you're 60, 65-year-old, then you're talking about more like 15 years. So it's very unlikely that you're going to have 2 valve interventions done in your lifetime. And we see that in surgery, right? Remember, before TAVR becomes even commercially available, everyone gets surgery. And very few surgeons, I would say, if you ask them, have 2 re-op AVRs have to be done, okay? Most of them now come back, maybe they had the valve done in the 50 to 60, now they're now in the 70s, or 60 to 70s, they now have the first time re-op AVR to be done. But you rarely have to have another valve to be done in the future because they just don't live that long. And remember, once you have the AVR done, your life expectancy is not going to be the same as the general population. So I think that if you have a surgical valve done the first time, and you have a TAVR valve done afterwards, which is now pretty much very common, it's very unlikely you're going to have require another TAVR valve inside that TAVR, not to mention the coronary obstruction risk and hemodynamics. On the other hand, if you have a TAVR done the first time, and even if you can't do a redo TAVR the next time, unless that TAVR combination fails, it's very unlikely again to be able to do a third TAVR because you have so much stent frame in place, you're not going to reaccess the coronary, you're going to have coronary obstruction. So again, unless you have some leaflet management strategy of the previous TAVR valve, and you're not going to cause any kind of hemodynamic impact, this is again very unlikely. So it comes back to this situation where you might actually have TAVR done the first time, but the second time your anatomy is not suitable for TAVR, so you have to have explant, so you need surgery. And then after that, if you live long enough to have surgical valve degeneration, which again is unlikely because now surgical valve have durability at least 15 plus years, then you can certainly do a TAVR and SAVR in that situation. So I think this is kind of interesting perspective on the pros and cons, but I would say there will be very few patients who will need 3 valve interventions in their lifetime. And if they do, then you should probably consider other possibilities, such as implanting a very large surgical valve in the first place that you don't have to worry about prosthesis patient match in the future, or maybe even the Ross procedure in expert hands, because that has shown to be very good long-term durability, almost in the same as the age-matched population. So I think in the summary is that TAVR is indicated in all surgical categories in AS, as you know. The lifetime management in AS and CD will be important, as you've seen, on which valve to choose, what procedure to choose with the first intervention. I do think if you have high-risk anatomy in lower intermediate risk patient, surgery still should be the alternative, especially in the concomitant surgery like CABG or mitral or tricuspid or AFib ablation. That really has to take into consideration. And again, in younger patients with low risk, especially bicuspid valve, we didn't even talk about that today. With hostile anatomy, we have really defaulted to surgery as the first intervention. Thank you very much, and I'll be happy to take any questions and discussions.
Thanks a lot, Gilbert. It was a great presentation. I have a question about the SURTAVI. You show the 2 survival curves are basically overlapping for the 2 groups. But as you know from partner 2A, for example, the landmark analysis shows separation of those groups in favor of surgery versus TAVI. Why do you think that for SURTAVI, which is the core valve, of course, system, there's no separation of those groups, whereas with partner, or at least partner 2A, the TAVI results seem to get worse with time, and surgery actually performs better?
Yeah, no, I think great question. People might say, well, it might be a class effect or valve effect. I mean, the reality is, unless you have granular data, you can't really compare the patient characteristics in a trial and what did it die of. But I think it is, pretty interesting to see one trial that there's a separation versus the other, and I think maybe hemodynamics may be important in terms of prosthesis-patient mismatch. Is hard to say, but it is a little bit offsetting. What struck me the most, as I mentioned in the study, is that despite the higher pacemaker rate in SURTAVI, obviously over P2A or even PVL, there was still no signal on mortality. I'd be curious to hear what you guys think, because obviously it's a European trial as much as with US centers as well.
Well, maybe see if somebody else wants to tackle that one. I have no explanation for it, to be honest. I would have thought with the higher pacemaker rate and with the core valve system that would translate into some sort of effect on mortality, but obviously it hasn't, at least within the confines of the SURTAVI trial. Let's see if anybody else has any questions regarding lifetime management or valve and valve, or TAVI and TAVI, etc. Matteo, you must have a question.
Quiet group. You guys are usually pretty vocal.
Well, I do have a question. I mean, this sounds everything very promising, but you're talking about very complex things that actually need a lot of expertise in very specialized centers. Do you think this is really going to be the reality of every TAVI center? And like, are we going to be to provide this kind of treatments like TAVI, valve in valve in most of the centers? Like, do you think this is really going to be the reality everywhere?
I mean, as you saw the graph, that was pretty sobering, at least to me. I mean, Mike Mack just sent me that slide last night and I showed it to you guys. I mean, I don't know how Germany is doing in terms of AVR volume versus TAVI volume. I mean, that is a huge drop. And actually, I didn't show you this a slide on mitral. So, actually, interestingly, 2020, with COVID hits, the number of tier, edge to edge, with MitraClip, which is the only device available in the US, it's now all more than isolated mitral valve repair in the United States, just slightly more. It's unbelievable how that trend is growing. I think this obviously, I agree with you. A lot of these more complex cases should technically be done in more experienced center, at least have a more equipoised discussion. Because remember, a lot of surgical outcomes that you see in some of these studies are not done, at expert surgical centers like yours. They're done in small centers and with suboptimal outcomes, and often surgeons are not comfortable taking on more complex cases. So they would just throw another valve in, like, it's straightforward transfemoral, but the outcomes will not be good. And we've seen now some cases where they were done outside and now come back to us and we have to, do surgery on them. And they are, can be very complex surgeries. So I think that is now what we surgeons have to deal with now that the proliferation of transcatheter technology, which definitely have a benefit and a role. But when we do an anatomy that are suboptimal or with suboptimal outcomes, particularly in the realm of paraviral leak, we've seen some cases where they were not suitable anatomy to start with because we had access to the pre-TAVR CT. They do a TAVR, okay acute outcomes, but then 30 days, 6 months later, already start to fail. And you see that in the data, right? In the published data, most of the valve intervention, even the redo TAVR registry and the explant, they were done within the first year, right? This is not like, I mean, it's very rare to see a surgical valve fail within the first year unless, there's some catastrophic technical issue. So a lot of them still intervene within the first year. And that's my concern, that they put a valve in, that's PVL now. You can't really fix PVL with another valve because calcium's in the way, you can't really plug it because it's technically challenging. So you're left with very limited options other than taking patient to the OR, to do it properly. And I think all of us are going to see more of that in the future as a specialty. And I think one of the challenges is teaching surgical trainees, how to deal with these. And they are difficult operations. They're not straightforward operations.
Okay, and I actually have two more questions. Again, to the topic, TAVR explant or reoperation following TAVR. Some cases are after degeneration of the valve. But actually, we also see a lot of endocarditis, and this is a real problem, and this is emerging as a problem, and it is increasing a lot. And these patients can only be operated. You cannot do valve in valve for these patients. So I don't know, how's your experience with that, and where do you think this trend is going? What are we gonna do with these patients? And the more low risk we do, probably the more endocarditis we're gonna see. Because we will have a bigger population. So yeah, we will have very sick people.
This is a very important question, a great point. So actually there's some recent data that you might have read that there was one study that showed really no difference in prevalence between surgery and surgical AVR versus TAVR in terms of endocarditis, prosthetic valve endocarditis. We published that series with Sophia, one of our residents in JAHA a couple of years ago, looking at the whole review of the whole spectrum. But you're right, cath lab is not as sterile as the OR. There might be some contamination risk, and we see that as potential risk because if you look at the prosthetic valve endocarditis, the microbiology is a little bit different between your surgery and TAVR in terms of prosthetic valve endocarditis. And there was a controversial paper that just came out, looking at these patients having surgery versus medical management. And by Joseph's group and Jack intervention, and show that there was no difference in outcomes. I think that is because that these patients were too far gone in their life cycle to be operated on. They probably should not be operated on. I mean, that paper, a good percentage of septic shock. And how patients coming in septic shock having surgery usually don't do well. So I think, and then there's also another group of patients. Actually, I'm sure you're aware of. The young patient, but on dialysis, those are at very, very high risk of developing endocarditis because of their underlying medical condition requiring dialysis with AV fistula. So, yeah, unfortunately, there's really no good way to deal with this. You gotta have to do complex redo root situation in majority of these patients, especially that involve a root abscess. And again, I think we're gonna have to train surgeons to how to tackle this. We're not going to stop people from doing TAVR, but I think dental hygiene is probably very important. I think that might have been underemphasized in patients who are undergoing TAVI. In fact, at our clinic now, we really make sure the patients are aware that after they have a TAVI valve, it's not a coronary stent. They need to have antibody prophylaxis when they go for dental surgery because it's a prosthesis like any kind of prosthesis they're having.
Okay, and my last question is, do you think there is enough evidence so far there is the discussion now about having TAVR centers without a surgeon in the background. And some cardiologists or interventionalists are starting to implant the TAVIs without surgeon in background. So do you think there is enough evidence today to state or recommend that interventional cardiologists should implant TAVRs without a surgeon in the background?
Yeah, no, this is a very controversial question, as you know, because the PCI the same thing, right? So then gone for the same evolution. So as you know now, there's no surgical backup for PCI. Before they would have, people ready for emergency cabbage. Back then with left main stenting. Now, of course, it's very much fallen by the wayside. I see TAVI probably in a similar, similar domain. For example, someone who undergone a BAV and caused a QAI, they're not going to call a surgeon. They're going to put a TAVI in, right, to treat that QAI. So with TAVR being proliferating, I think it's going to be a more regulatory policy or rule. So in the United States right now, you're still required to have surgical presence, surgical experience to qualify as a TAVI center. So if you don't do any AVR, you cannot be a TAVI center, even to maintain your program. So that's regulated by the government. So once the government decides what to do, if they decide not require for surgical presence or surgical backup, then basically you cannot stop that from happening. For us, we had the discussion where do you require a perfusionist on the team? Do you require operating nurse on the team at all the TAVRs? We're now having the discussion. Certainly, I think if it's straightforward anatomy, normal ejection fraction, no comorbidities in terms of very bad pulmonary hypertension or severe MRTR concomitantly, they're high surgical risk. Maybe those patients you can do it without any kind of perfusionist or OR staff being present. But anything that anatomical difficult or potentially conversion risk that potentially may need ongoing cardiopulmonary bypass, then we definitely have the whole team there. I think that's just for safety for the patient. So I would say majority of the patients do not require that. But remember, at least in US, I just recently looked at the breakdown of the percentage of low risk, intermediate risk, or high extreme risk patients that undergoing TAVR now in the United States. Only about 28 to 30% of patients in the United States now are deemed low surgical risk. So about 35% and about 30-something% are considered intermediate and high surgical risks. So there's still patients who are high surgical risk out there who are getting TAVR that might need to pay attention to. Even though we might not be opening the chest or doing surgery, but they still need to be maybe on pulmonary support or other things, left main protection, etc., to be able to safely do the procedure. So I think it's going to be ultimately up to the government and regulatory approval. But in the meantime, I'm sure it's all politics being local. There'll be a local decision and the hospital decision. And if the hospital decides not to do that, and obviously they could be subject to medical legal consequences, which of course in the United States are much more prevalent than maybe in Europe.
Well, I actually think that the surgeon on site is even more important in low risk. And give me a second. Sorry, I have like an echo now. So I actually think that the surgeon in the background is even more important in low risk and intermediate risk patients, because if you have a low risk patient and he dies because of a intra-procedural complication, that's basically not acceptable if the patient died because there was no surgeon. So I kind of think like the lower the risk, even more important a surgeon to be on site.
Yeah, we actually have a paper coming out on that, and Gilbert, showing a quite acceptable survival rate in the low risk patients that needed emergency surgery during their TAVI procedure, as opposed to the intermediate and high risk that they're just, basically lost cases.
Right.
I have to agree with Matteo. And it's just our single center experience, but it's still a reasonable number of patients. And
it's very important. And Mike, I think we, knock on wood, for the past 2 years, we did 450 TAVIs last year. We had not had a single coronary occlusion because we have a very low threshold to protect and stand. We have a great interventional, team with working together here. So I think a lot of it had to be pre-case planning. So anyone with low EF, we typically put 2 veins in there, one for T pacing and one to go on bypass if we need to. Because you just, usually bad things happen after the valve goes in, not usually before, unless, there's some technical issues. And you have the sheath already in place that you can just put a cannula right through it. You don't need to have blindly stick anything. And the first thing we do is just to go on pump as quickly as possible and then deal with whatever situation at hand. And that has allowed us to salvage quite a lot of patients, actually. So I don't know how your center does the contingency planning, but for us, at least, we do that preemptively, so no one is surprised or anything. We sometimes have epi on the table. We can do intracardiac, intra-aortic epi if we need to, for brief resuscitation. But we agree with you absolutely 100% that they are definitely salvageable, especially in low surgical risk.
Okay, Gilbert, thanks very much, Matteo. I think we'll probably let him get back to his hybrid OR. Gilbert, thanks very much. That was fantastic. And we look forward to continuing to collaborate with you and your team for years to come.
Yeah, hopefully I'll bring my whole family to visit Germany again once all this stuff is over. Yeah,
we would look forward to that. Thanks a lot, Gilbert.
Thank you, Matteo, for organizing everything. Thank you, everyone.
Bye-bye.
Bye-bye.
Thank you.
Bye.